Studio MSMA roundtable. Dr. Jennifer Bryan, live and in living color. Good morning, and it's good to have you here.
Good morning. I'm so glad to be back with you.
No
Paul.
power outages
There
on
we
this
go.
one. Mississippi State Medical Association Board of Trustees Chair, Dr. Kimberly Crowder, Chair of Ophthalmology, University of Mississippi Medical Center. Dr. Crowder, good morning. How are you?
Good morning. Thank you for having me.
And on the phone, it is the one and only Dr. Brian Batson from our hometown of Hattiesburg, Chief Executive Officer, Hattiesburg Clinic. Dr. Batson, good morning, sir. Can you hear everything okay?
Absolutely. Good morning to everybody.
Good morning to you. Now, this is kind of complicated. I was talking to Dr. Brian and also Dr. Crowder just a few moments ago, Dr. Batson, that this thing matters, and we want to tell people in the selected time that we have why it matters and what is going on. And I'll let anybody jump in on set the stage, exactly what is happening that will affect people's lives as far as the optometry and ophthalmology and what you guys are involved in. Dr. Brian?
Good morning, Paul. Thanks again for having us.
Certainly.
Such an important topic, and I know your listeners are going to be interested in how this affects them and how it affects their family. We've got two very important bills before the legislature that we're discussing regarding scope of practice. Mm-hmm. We've got 1302 and 1303, one being the optometry, which would extend the ability of optometrists to perform surgery like the ophthalmologists do, including laser surgery of the eye, which we obviously have concerns about regarding those who did not go to medical school performing surgery on the eye, and I'll let Dr. Crowder speak more to that shortly. Additionally, we've got scope of practice with nurse practitioners again, and this is interesting because it pits the team against each other from the get-go. Our beloved team members that work so closely together are doctors and nurse practitioners. We have been reached out to, and I've been heartened by our nurse practitioner colleagues across the state who are collaborating quite well with their doctors, so they have backup. We enjoy working with them both in the same location as well as, the boundaries have been extended statewide for primary care, so it's a lot easier to find a physician to collaborate with. What this bill would do would be remove the physician from a physician-led team. Therefore, there would be two silos of care in Mississippi, one in which a doctor has a hands-on in providing backup and some oversight to the care that's provided by the current team members, the nurse practitioners, and then another silo where there is no medical school-trained physician, no residency-trained physician involved in the care of our patients. We know that Mississippi has very sick patients, and so we're quite concerned about our rural areas basically removing the physician expert from the care of those patients.
They can do it optionally, but it's not mandatory as far as having a physician part of that.
Right, optionally. And of course, yes.
So what we're talking about in some rural area of the state, the only medical people they have there may be a nurse practitioner.
Well, and currently
they have that now.
Right, and currently physicians, as you know, outnumber nurse practitioners in rural Mississippi, and MSMA has been we've made great strides in increasing access to care.
But this is not in 1302 or 1303. Is it in another bill, or is it encompasses that bill?
The
nurse practitioner.
Yeah, I may have the numbers back.
No, I was going to say, but 2000. But let's see, it's 2763 is the optometry bill.
Okay.
2007 is the nurse practitioner bill. I think that's it.
Yeah, I'll check the numbers at the break.
So when you're looking at that, and we'll have people go in and see, just read that and see what the scope of practice is according to this. Who's pushing the bills?
So we've seen a lot of ads statewide with the Mississippi Association of Nurse Practitioners. Interestingly, again, our colleagues have expressed different opinions, the nurse practitioners, than their own organizations do. Nationally, there's a push. We're seeing this countrywide, almost a coordinated attack by the organizations across the country in multiple states. It's happened very quickly over recent years, so we hear this number of, well, so many other states have done this, why not us now? This has all happened very quickly, and the numbers have stacked up, but still the majority of states are physician-led.
So the way this would change is there would not be a medical doctor's oversight in some of these clinics. It would just be a nurse practitioner.
Absolutely, and that's behind the scenes. Most teams in Mississippi collaborate happily. The physician is involved. We hear these arguments minimized about chart review or there's barely any collaboration. Most collaboration is free, and most collaboration is intensive. The other thing we hear is having to pay for a doctor. Most collaboration, again, is free. These folks work in systems together alongside their colleagues. We see that if a nurse practitioner opens their own business.
Yeah. Let me ask Dr. Batson, I don't know if you want to get in on this one as far as nurse practitioners, Dr. Brian Batson, Chief Executive Officer, Hattiesburg Clinic. But hasn't telemedicine changed this a little bit too, changed the whole verbiage on nurse practitioners to some degree? Dr. Batson?
Yeah, that's a great point to make as well. The access has become easier, which is a good thing for patients, especially through COVID, that we've had improved access to healthcare providers. However, as Dr. Bryan stated, and I agree with completely, is we have to be very careful about how rapidly that access becomes available and how much oversight is a part of that access.
So you as Chief Executive Officer of the Hattiesburg Clinic, what are the issues that you are concerned about as far as these bills are concerned?
Well, I think, everything that Dr. Bryan stated is well stated. Where we were at Hattiesburg Clinic around 2019, and she spoke to the rapid growth, and we saw this in our own organization, which is a very positive thing for us. In 2005, Hattiesburg Clinic had 26 nurse practitioners, or APPs, Advanced Practice Providers, in the organization in 2005. Fast forward to 2020, and there were 186, and that's a phenomenal growth. And working in a very good relationship with our physicians in collaborative fashion as part of a team caring for patients. So we decided to take a look in 2019 at, what did this rapid growth mean for us as we looked toward the future of value-based care. And when I use that term value-based care, I'm talking about those things that Medicare and other payers are asking us to do as we see patients, in really focusing on high quality of care coupled with low cost of care and patient satisfaction. So that term value-based care really encompasses that triad of high quality, low cost, and patient satisfaction. So we took it upon ourselves to use that experience that we'd had in the 15 or so years of growth to look at the data associated with the care teams, both physician-led and in those situations where a nurse practitioner or a physician's assistant was serving as a patient's primary care provider.
Yeah, let me ask you this before we run out and a break hits here, because sometimes I think what happens is we're getting the general public is a little bit confused. Not so much confused, but it seems to be family medicine doctors are not available, so you put a nurse practitioner in there, and there's not a lot of difference between a family medicine doctor and a nurse practitioner. But then you start looking behind the scenes of the quality of the education and what they had to go through. There's and stop me if I'm wrong, Dr. Bryan, but there's a vast difference between that. And then you start comparing what's the difference between a registered nurse and a nurse practitioner.
Absolutely. No, that's a great question. I'll follow up to Dr. Batson's comments that there is no substitute for medical school. We work together. These two professions were designed to work together, the quarterback being the physician. Each physician has at least 10,000 hours of clinical training, minimum up to 20,000, and even more if you count the medical school hours. The nurse practitioner trains in a model of 500 shadowing hours. That does not involve all the critical decision making that the physician has made in going through medical school and learning to diagnose. So there is some diagnostics. There's overlap.
Well, also, we get a little bit above that as far as the filing the records and everything else that are required. Some things are required from a doctor to sign off on himself. What about the malpractice insurance and all that? And the question is there, too, why was that classification even created in the first place? Why was nurse practitioners created?
I'd love to speak to that.
Can we do that?
Absolutely.
Dr. Crowder, I haven't forgotten you. You'll have the whole 30 minutes coming up next.
Oh, perfect.
So stand by. Warm up. We're coming. We have a MSMA roundtable going on. Dr. Jennifer Bryan. On the phone is Dr. Brian Batson, Chief Executive Officer, Hattiesburg Clinic, and also Dr. Kimberly Crowder, who is with the chair of ophthalmology from the University of Mississippi. Now, how does this affect the scope of practice as far as ophthalmology, Dr. Crowder?
So this is very important for all eye care patients. And let me start with reiterating what Dr. Bryan said, that teams are incredibly important. And we need optometrists and ophthalmologists working together in the state in order to serve all of our patients. However, as an ophthalmologist, having gone through 4 years of medical school and 4 years of residency in order to be trained to do what I do, I know that the medical school portion of this and the residency training is not insignificant. The 8 years compared to 4 years really does matter. This is for surgery procedures, this is for diagnosis, this is for understanding, when I need to refer a patient to a specialist that's even trained beyond me, a subspecialist in ophthalmology who's done additional fellowship years. So there are lots of years. This is not just hours to become a surgeon. There are years and years to become a surgeon. Medical school curriculums are standardized across the country. Ophthalmology residency curriculums are standardized across the country. This is a result of the tried and true, let's see how this works and how to best train a student who starts at the beginning, and completes medical school to become a doctor and then do 4 years of residency and beyond to become an actual surgeon.
I got you. So what is it that the optometrist want to do that they're not permitted to do now?
So they would like laser procedures. They would like scalpel eyelid procedures. So this is that with the understanding that they go back for more training? For the laser procedures, they they want to do a pilot program of 32 hours of training. Like I said, this is not the days, weeks, months, and years. This is a number of hours. To put it into perspective, I spoke in front of the Senate Public Health Committee about this, and I have a 16-year-old who learned to drive this past year, and with COVID, I now have to sign an affidavit because there's no more one-on-one with the officer sitting in the car with the student during COVID. So I had to sign an affidavit that I had personally trained her for 52 hours to learn to drive. And their bills puts in their 32 hours to learn to do laser surgery.
What's the education for an optometrist compared to an ophthalmologist? You said 8 years. You have 8 years
Correct.
Total.
So an optometrist does, undergraduate prerequisite courses and does 4 years of optometry school and then is allowed to practice. A physician does 4 years of the undergraduate, does 4 years of medical school to obtain their medical degree, and then does for ophthalmology an additional 4 to 6 years in order to become a specialized surgeon.
I can understand the scope of practice because it is encroaching on a field, and it does get back to money, too, and to business. A lot of the business and to pay off student loans and to continue the business that you have depends on those peripheral patients that you see for that. Am I right?
It does, but when it comes to patient safety,
there is a monetary argument in this, too, though.
There is, but for patient safety, we believe surgery should be performed by surgeons.
So let me ask you, Dr. Bryan Batson, if something screws up and they get to an area that they may have just extended themselves a little bit, I would guess then they go to an ophthalmologist.
That's correct.
That's it.
But that's not a requirement.
I got you.
There's no particular oversight of this.
All right, who is pushing this? Dr. Bryan Batson. Well, let me better still asking Dr. Jennifer Bryan, who's with the Medical Association. Who's pushing this? Is it the optometrists themselves? Is it the lobbyists? Who is? And why do they want this? I understand scope of practice is always a battle out there.
Right. Yeah. No. It's the lobbyists. It's also their national lobby. There was a lot of national push in the lobby last year, kind of spilling over into this year. Why they want it? Just like most things, it's under the guise of access to care, which we firmly disagree with, and always, we look for monetary interest. You asked me earlier about why nurse practitioners came to be. You want to speak a little bit about?
Sure,
Yeah.
go ahead.
So, I came along with in the 80s as a teenager coming in my uncle's private practice, family practice, and I watched as we had trusted RNs that could go ahead of the doctor to the hospital to, yes, he's going to want a chest x-ray or she's going to want a CBC on this one. Those trusted, intelligent nurses, they kind of developed a track for an extension and to monitor some blood thinners and things. It's gone. Their field has extended. It has extended. But still, the training is nowhere near that of the physician. And so as it kind of morphed, where we find now is we're having to actually prove that medical school matters, which is what Dr. Batson was pointing at. The clinic, the Hattiesburg Clinic's data is so clear. They are the #1 ACO in the country, which doctors are paid by value-based care, how good we provide care. And they've just got an excellent model. The American Medical Association has pointed to them as a shining example that they proved over the past decade that physician quality is superior and that nurse practitioner quality of care is improved when the physician is involved, and also there's decreased cost. I have great concerns about our state Medicaid programs, the cost of care if we remove the physician from the medical care of our patients.
I haven't had a definitive answer as far as malpractice and nurse practitioners. What's the definitive answer to that? Do they have to have malpractice insurance?
They currently do have their own policies.
They do have their own
physician
policy.
has their own policies, but right now, as we are together, there's liability on all involved, right? And that's.
And right now, the law states that they can have their own practice, let's say in a rural area somewhere, but they have to have a doctor signed on somewhere?
So that's the stories that you hear. I'm going to open my practice, and I can't find a doctor. Well, but they have enough money to start a business and to own it, and then they contract the doctor. We have given every year at the legislature, now it's to the state borders. You have the entire state of Mississippi to find a doctor to collaborate with you. And if not, the Medical Licensure Board is a backstop to help find a collaborator.
What's the cost factor in that?
Of course, it's the free market. So what you negotiate.
They can negotiate anything they want.
Absolutely. However, in most clinics, the collaboration I've always done has been free.
Yeah, well, even so, if you're doing that, you can do more collaboration now as far as telemedicine is concerned too, couldn't you?
And telemedicine is so amazing. We're getting our doctors to rural Mississippi. It's just, yes.
Let me get Dr. Batson on. Your thoughts hearing all of this, sir.
Agree with Dr. Bryan and Dr. Crowder's comments. It is really a focus on how do we best take care of the patients, and that's been the physician focus and nurse focus for a long time. So let's align those goals and continue to work as really functional teams that are not pitted against each other, but these teams that reach those goals of value-based care. It's worked very effectively for Hattiesburg Clinic for many years. We examined our process, and we're refining the process based on what we've learned in that experience with some amazing nurse practitioners and PAs that have worked with the organization to continue to improve upon those relationships between the physicians and the APPs.
Got it.
So that we're providing better care.
Let me ask Dr. Crowder, where do we go from here? What are you guys asking for? Is this just take another look at this? Don't let it out of committee. Where is it?
Well, it's already out of the committee.
It is out of committee.
But we do not want this to go into law. This is not good for our patients in the state of Mississippi. This is not good for their safety. This is not good for their high quality of care.
Your thoughts, Dr. Bryan, finally?
Yeah, a lot of things were asked as how will this affect my family? We've got sick folks in Mississippi, and we are committed to getting doctors to rural Mississippi.
You think this makes the quality of medicine in the state less?
I absolutely do. If you remove the doctor and you magically grant with a pen independent practice of nurses, okay, you have not increased their access one iota, not one more appointment slot. You've simply decreased the quality of care and created two standards of medical care in Mississippi, one in which there is a physician who went to medical school and residency and one in which there is not. Our doctors are innovative and committed with the Office of Physician Workforce. Our programs are working.
Yeah. I think one of the things that people will resonate with the general population is, do we have a shortage? Areas that we do have a shortage. Do we have a shortage of ophthalmologists?
So we have ophthalmologists all over this state. 77% of the Mississippi population is within 30 minutes of an ophthalmologist, and over 95% is within 1 hour.
Great point.
So they can be referred.
Final segment with this, all three, Dr. Jennifer Bryan, Dr. Kimberly Crowder, and Dr. Brian Batson, coming up in a moment or two. And okay, not a lot of time in this segment here, but I want to give all three of the good doctors a chance to do their final thoughts. And let me go to Dr. Brian Batson, again, the Chief Executive Officer, Hattiesburg Clinic. And your thoughts, sir, and your final thoughts on this.
Just, I think it's important that we continue to focus on what's best for our patients. In my part of the state, in South Mississippi, in the Pine Belt area, that is a focus, and it's a focus around the rest of the state as well. Mm-hmm. And to that end, this is an important issue that we need to remain focused on to keep our teams functioning in the best way possible with a physician at the lead.
If this happens, is there a date from the Mississippi Medical Association to Dr. Jennifer Bryan? Were there some mandates that the consumer, the patients, are going to have to be notified exactly what they were able to do? Do they have the training now, or is there any information that goes out to the parent or to the patients that the scope of practice has changed and they can do this now?
You know, I don't know about that, but I believe so strongly in this that it'll be very public knowledge if and when we have to deal with this. But I'll say that it's just so important that this does not become law for patient safety.
Your organization doesn't bring in the Dental Association. Is that different?
Right, we're separate. Right,
you are separate. Mm-hmm. But I mean, the scope of practice also is one of the things that they look at too. I mean, everybody's doing the same thing, trying to kind of enlarge that scope of practice.
Well, it's always. I mean, always people are going to push the envelope, and we are always going to be the bad guys with our backs against the wall, saying this is not safe, this is not okay. But we value our colleagues, and I want to make that point.
So it means you cannot rest the first 3 months of the year.
Ever. But we like it. Aren't we crazy?
You have to have ADD then. Dr. Brian Batson, thank you, sir. Appreciate it very much. We thank you for joining us. And then Dr. Kimberly Crowder, here are your final thoughts, ma'am.
Just patient care, patient safety is utmost of our priority, and surgery by a surgeon, by a doctor who has gone to medical school and done the appropriate surgical training is what is key for good patient care.
All right, now, so we got about a minute left, and we finally booked. Perez, you haven't gotten your first shot yet, have you?
No, I haven't been able to.
By the way, I just saw a bleep that came in a few moments ago that in the Mid-South, Walmart's going to start giving shots.
I don't know if I want to get a shot at Walmart.
Well, it's not like a Walmart vaccine.
There's certain things I don't want to get underwear and fruit at Walmart.
You can get glasses there.
I'm not getting. I have an actual doctor that you know.
Well, I understand that, but I mean, it's not like the Walmart vaccine that's on sale and it's over on the produce aisle. You're an idiot.
I'm not an idiot. I just don't know.
And I think it's going to be only in the Memphis area right now.
Well, I don't live in Memphis.
I'd encourage you guys to get the first shot available to you wherever you can get it.
Yeah, I got the first shot. We just got it booked yesterday. The second shot coming up in about a week. I think it's next week, a latter part of next week. But I ask both of you who have gotten your second shot, and both of you Pfizer?
Yes, correct.
That what were the after effects, and both of you didn't give me the answer that I wanted. Dr. Bryan, the second shot, apparently the first shot went good, which I had a little soreness, but nothing. But the second shot?
I've been nothing but transparent about this pandemic. The second shot, expect. Some people have no problem, but I a little low-grade fever, a little achiness for about 12 hours, responded to Advil. I took it easy and watched some Netflix and was fine, but I did have a little flu-like symptoms there for about 12 hours
About 12 hours?
Yeah.
You took Advil?
I did.
You recommend Advil? Well, I don't want you to recommend anything, but Advil is one of the things you can take.
Yeah, I did like several hours after I took the shot. I didn't take it beforehand, but I took it several hours after.
Was it high-potency Advil or just regular Advil?
I just took a
couple. Why are you trying to get this woman in trouble?
No, I'm just trying to figure. I'm trying to prepare.
Hey, Perez, it was Walmart brand ibuprofen.
Oh, shut up!
I tell patients that means that the shot is working. That if your immune system's having some response, then that's a good sign.
But why is that though? Why would the second shot? It would seem to me the first shot would be the one that you'd get some reaction from.
I'll let you answer, Jennifer.
Well, you just need the memory response is building up. So you got the first one, you get a response, it settles down, then you get the second one, you get that robust response.
Both of you, I know you both stay on top of this, but some of the genetic changes in this thing, does that worry you a little bit, or is it you? We've been told that the vaccine should cover that too.
The more we let the virus spread, the more we're going to see variants. And so it's just important that we race to get the vaccine out and that we test, track, and isolate these variants as they pop up. I'm not overly alarmed. The vaccine is very effective, and with the technology, they can change it up and we can get boosters. So I'm still very excited about the vaccine and the effects that we expect it's going to have on our population.
So you have been told that your percentage of protection now is what, about 90%, 95%?
Yeah, 95% on the Pfizer right now, yeah.
On the Pfizer?
Yeah.
That's a good thing.
I saw Johnson & Johnson had a report this morning that the efficacy there is about 66%. That's a little low.
It is, but, zero is even lower, so we will.
And it depends on how many people get the vaccine. That is what is so important here.
Walmart brand is 12.5%, but you get a great deal on it.
Shut up.
And you get a coupon for some vegetables.
Thank you for having us.
Thank you so much.
You guys, thank you so very much. We are smarter now and know what the ins and outs are. Call your legislators if you like it or dislike it, one way or the other. But
it matters.
It will be moving over from house to house, and they'll be cogitating, and you know how the process is.
We're going to keep the team together.
Keep us informed.
Thank you.
Thank you. Have a C-Spire roundtable.